Pleasant evening to everyone here. On behalf of SNO, India, Tamil Nadu, we wholeheartedly welcome you all for this grand event, ADRENERGIX 2.0, a medical extravaganza. The first day of the program is exclusively planned for poster presentation, an exciting forum for students, researchers, healthcare professionals to share their innovative ideas and advancements in medicine and by focusing on the latest breakthroughs in healthcare. This competition serves as a catalyst for improving patient care and advanced medical knowledge. On this occasion, I'd like to invite our judge of the event, Dr. Priya Bantani ma'am, Professor, MD Pathology. Uh, she is academic coordinator at Trichy SR Medical College, Hospital and Research Center. With 18 years of experience, she has published 12 research articles in the field of pathology and medical education in national and international journals. She has received Best Paper Award in International Pathology Conference as PG, Best Poster Presentation as part of Advanced Course in Medical Education as faculty in CMC Vellore. Uh, she is an executive member of TNPC IAPM, life member of IAPM, and life member of Indian Medical Association. Every learning has its own backyard. Every step has its own courage, and every framework has its own style. Every action has its own syllabus. And now I'm so happy to introduce all the finalists of the event: Shashireka, Shweta, Priyadarshini, Rakshana Prabhakaran, Neha Jaglan, and Deepika. Uh, I request the delegates to wait outside till their turn. And the first one to present the poster will be Neha Jaglan.
Before the presenter starts, I would just want to say that the poster presentation judging will be based on the clarity of presentation, on the content which you are presenting, any innovative idea which you have come up with, and your explanation to the questions I put forward. So my markings of your talk will be on this. And I guess the time limit is 5 minutes, right?
Yes, ma'am. 6 minutes, ma'am. After 5 minutes, a notification will be given. Guys, be ready. The first presenter. Yes, ma'am.
Yeah, who's the first presenter?
Ma'am, Sasi Rekha. I'm sorry, Neha. The first presenter will be Sasi Rekha. Other delegates, kindly please wait outside. And Sasi Rekha, you can share your screen and present your poster.
Good evening, ma'am. Myself, Sasi Rekha, studying third year BDS from Ragas Dental College. I'm here to present on the topic Disruptive Approach to Cancer Research and Survival. Ma'am, am I audible?
Yes, you are. Can you show me your poster too?
Ma'am, myself Sasi Rekha, studying third year BDS from Ragas Dental College, and here to present on the topic Disruptive Approach to Cancer Research and Survival. To start up with the introduction, cancer has plagued humanity for centuries and continues to cast a long shadow over global healthcare. The significance of finding new disruptive approaches to enhance cancer survival rates cannot be overstated. The urgency toll cancer takes on patients and their families, as well as the strain it places on the healthcare system. The primary objective of this poster presentation is to shed light on the concept of disruptive approaches in cancer research and survival. So, when we start about why we have to research on cancer treatment and diagnosis, why we need advancement is that we have many challenges in the past days. The limitations of existing cancer treatments include the side effects of chemotherapy and the difficulties in achieving early and accurate diagnosis. And it also includes the financial burden on patients and healthcare systems, and the relentless adaptation of cancer cells to treatment regimes all highlight the urgency for disruptive change. We could see what is a disruptive approach first. It represents a break from conventional methods and established norms. It is often marked by unconventional thinking, groundbreaking technologies, and a vision that defies existing boundaries. To start up with my approaches, which I have been uh, researching first, I could start up with the artificial intelligence. Within cancer imaging, AI finds great utility in performing three main clinical tasks. The task would be the detection, characterization, and monitoring. Detection refers to the localization of objects of interest in radiographs. Within a pattern recognition context, regions with suspicious imaging characteristics are highlighted and presented to the readers. This enables a much more precision in detecting a cancer than a human eyes, the doctor's eyes as well. So the second will be the characterization, which captures the segmentation, diagnosis, and staging of tumors in cancer. To continue with the characterization, it can also provide prognostication and outcome prediction based on certain treatment modalities. So what I'm talking about, the segmentation, which defines the extent of an abnormality in terms of 2D or 3D. So it would be more clear to the clinicians. Okay. And what the diagnosis could also be better when it is seen on the AI. And the third will be the monitoring. It is capturing a large number of discriminative features that go beyond those measured by traditional evaluation criteria. By this, I would prefer that AI, once AI comes into the practice of detecting cancers, it could be much better. And the next approach which I could describe is the MCED, which is an ever evolving landscape of medical technology and innovation that could revolutionize cancer screening has emerged. That is none other than multiple cancer early detection that have captured the attention of doctors as it has the potential to detect a range of cancers through a simple blood test. It is actually a liquid biopsy test which measures the biological signals that cancer cells may shed in the body fluids. That is the biomarkers. The main thing with where it differs from other tests is that it uses a single blood test instead of X-rays, imagings, and more invasive medical procedures which we were using before this. And it checks for many types of cancer from different organ sites at the same time. It reduces the time involved in detecting a cancer in the normal traditional techniques. And though it is evolving, we have a little bit of disadvantages there, which we can also show some false positive. The future researchers had to work upon it to make it more effective. And the next which I come about the approach is that CRISPR, which is the acronym goes like cluster regularly interpret short palindromic repeats. It is a genome editing tool which can modify the DNA sequence of a living organism. Ever since scientists realized that changes in DNA cause cancer, they have been searching for an easy way to correct those changes by manipulating the DNA. Okay, so it is the first described and commonly used gene editing tool was CRISPR Cas9, which was derived from the Streptococcus pyogenes. And if we talk about the clinical trials as of 2023 update, in November 2022, CRISPR Therapeutics shared preliminary results from a trial using their allogenic CDTO targeting CAR T cell in individuals with solid tumors in kidney. The treatment was well tolerated and without any serious side effects. 77% of control was achieved by this method. And I could mention you some other gene editing tools also, which goes by TALE nucleases and zinc finger nucleases.
The last one
And
minute, no?
ma'am,
Your last 1 minute.
yes, ma'am. And we can go by, then we have the immunotherapy. It is none other, the immuno-oncology is a form of cancer treatment that helps or aids the immune system to fight against the cancer. We have various types of immune therapies here, like immune checkpoint inhibitors, T cell transfer therapy, adoptive cell therapy. And the researchers have been going through that to enhance it much more in a better way, where our own antibodies will be much stronger and effective to fight against the cancer cells. And the last we have the cryo-electron microscopy, which is used to uncover new cancer pathways and enables to obtain an atomic level description of key cancer protein targets and a framework for improving pharmaceutical interventions. It actually cryo-electron microscopy is something which enables us to look at the much clear and modified structure of the
Sashilekha,
receptors which acts for cancer. Yes, ma'am.
your time is up.
I could like to conclude my speech as disruptive approach to cancer research offers a promising path forward. By embracing new technologies and methodologies, we can redefine the way we understand, prevent, and treat cancer. Interdisciplinary collaboration among scientists, clinicians, engineers, and data analysts can spark creativity and accelerate breakthroughs in cancer research. Thank you, ma'am.
Thank you, Sasileka. I think you did a good job of putting away whatever you wanted to say in a good poster. Now, where did you get your references from? Did you read any articles, or what were your references?
My references were from NCIB, and I have gone through several articles which were being posted, cited in the cancer research theories by America and Russian countries. I went through many articles, ma'am.
Okay. Are there any as far as I've read, are there any surgical procedures which can come under disruptive approach to cancer? You have
Uh, we could uh,
yeah.
we could have some laser robotic surgicals can
Okay.
also be a disruptive approach, ma'am.
Okay. What is the main essence of a disruptive evolution? Why should we have a disruptive innovation? What is the main? Why do they do this? The basic. Already we
The
have lots
base
of therapies coming up. We have lots of surgery kind of approach. We have, as you said, immunotherapy and all that. Now, what is the difference between that and this disruptive approach?
Ma'am, in all the fields like diagnosis, let it be treatment and management, we need a disruptive approach, ma'am. For diagnosis, where we do the MCED, it is for early detection, where we could diagnose a cancer even before the symptoms appear. So we could treat the patient much better. And
Okay.
when it comes for the treatment, we could use robotic surgeries, where the surgeries could be precise.
Okay.
Yes.
Thank you, Sasita.
Thank you, ma'am.
Thank you, Shashireka. That was a really good presentation. The next one to present is Shweta.
Can I start it now?
Yeah, sure.
Yeah. So, good evening to the judges. I'm Shweta V, third year BDS student from Raga's Dental College. So, I'm here to showcase my poster presentation on disruptive approach to cancer research and survival. So, before moving on to this poster presentation, I would like to share my view on this topic. I see this as a beacon for a promising future, a beacon of hope for the promising future. I see this as a catalyst for innovation where innovative strategies are put forth for the cancer surviving patients. Yes, moving on to the introduction part, disruptive approach to cancer research and survival. This is something a groundbreaking strategy. Departure from the conventional methodologies. Conventional methodologies, I mean the surgery, radiotherapy, chemotherapy, where this disruptive approach, it is a new generation tactics. Um, Apart from the earlier strategies where lot of disadvantages are being put forth, especially the side effects, disruptive approaches, they don't put a lot of side effects to the patients. Moving on to the objectives part, enhance the early detection. Yes, any disease it may be, early detection is better, a safe part. An ounce of prevention is worth a pound of cure. We all know that. So, any early detection of cancer, we all know cancer at earlier stages is going to remain localized. So, early detecting the cancer can give a tailor better treatment plans, and it also increases the quality of the survivorship of the patients. Next is treatment plans. How are the conventional treatment plans been? They just follow one pattern. One size fits all. That is how the conventional treatment patterns were like. But this disruptive approach, it gives an individualized treatment plans for the patients. They go through the genomic analysis of the patients and they provide individualized treatment plans. Next is the multidisciplinary approach. Why I call this as a multidisciplinary approach is that this disruptive approach, it invites expertise from various fields: biology, genomics, data sciences, data informatics, engineering. It all puts the specialized skills of these expertise into the table for a specific issue and thereby I call this as a multidisciplinary approach. When all the above three objectives are put forth properly, the fourth objective obviously is being followed. It increases the survival rates and the quality of the patients. Next, moving on to the key approaches of this, is that I see these key approaches as pillars of disruptive approaches to cancer research. So, moving on to the targeted therapies. Targeted therapies, from the name, it indicates that the therapy is being targeted to one particular cell that needs this. So yes, it is a cancer cell. So targeted therapies are the cancer cells are being targeted. One advantage I see in this therapy is that it spares the healthy cells. Only the cancer cells are being targeted, and the other healthy cells are being spared away, and thereby it also reduces the side effects. Next is the liquid biopsy. On my view, this liquid biopsy is a non-invasive one. Apart from the conventional biopsy that we all know, where a tissue section is being cut, it is quite invasive. But this liquid biopsy is just taking the blood sample from the patient, and just giving a gist over how it is being performed is that the blood sample from the patient is being collected, centrifuged. On centrifugation, the plasma is going to separate out and come. Now, this plasma is going to have cell-free DNA. When I say cell-free DNA, it contains the tumor DNA produced by the tumor cells also. Now, this plasma containing the healthy DNA and the tumor-produced DNA is now being separated. The tumor DNA are being extracted, and this is being sequenced, and this is being studied by the oncologist and medical pathologist for patients' treatment plans. Next, coming to the immunotherapies. Immunotherapies, from the name, the therapy that uses the immune system. Here, this therapy uses the body's natural defense mechanism to destroy the cancer cells. Examples for that includes the checkpoint inhibitors. Checkpoint inhibitors are, we have some protein blocks. So, certain immunotherapeutic agents, they block these certain immune proteins, thereby activating the immune system to destroy the cancer cell. Next is the CAR T cell therapy. CAR T cell therapy has found to be a revolutionizing therapy in immunotherapies. The reason is that the CAR T cell therapy, the T cell, a lymphocyte that is being modified. So this is being modified to defeat the cancer cells. Next is cytokine therapy, where it boosts the immune system. Apart from these, other immunotherapies include other cancer vaccines being introduced recently. Next is the oncolytic virus. We all know what a virus does. It goes, infects the normal cell and kills it. Exactly in the same way, oncolytic virus, they infect the cancer cell and thereby they kill the cancer cells. These are all adaptive cell transformations where we utilize the body's mechanisms. Apart from this is the lab engineered antibodies, which are the monoclonal antibodies. The next is the gene editing.
Shweta,
Yes, ma'am.
your last 1 minute.
Okay, ma'am. Next is the gene editing. Gene editing, one most important I see is that the CRISPR-Cas9, where this CRISPR-Cas9 is the bacterial protein that, along with a guide RNA, is being sent into the is being sent for the gene cutting. They act as molecular scissors for gene cutting, and it is basically a deletion insertion process, thereby disrupting the cancer DNA. Next is the AI-driven analysis, where early diagnosis is being made and for patients to tailor the treatment plans. Two most fascinating points that I would see in AI is that natural language processing. Any language it may be the records, clinical records or clinical notes. It assesses all the languages and gives notes, proper information to the clinicians for proper treatments. Another thing is that privacy of the data. At times, patients or even the clinicians may misplace or lose their patient records, which the AI driven, it safeguards and it also protects by giving the privacy. So, ending my presentation by saying that this disruptive approach is a new generation tactics where more and more researches has to be performed on this. So, the reason is that cancer patients, we all know that once the cancer comes, the survival rate of them is put at a question mark. So this gives an answer for them where it increases the survivorship of the patients also, and thereby this has to be continued, and more researches has to be done in this cancer research. Thank you.
Uh, Thank you, Shweta. That was a very wonderful presentation. What do you think in a developing country like India, how far do you think this is going to work, disruptive approach to cancer? And what do you think are the advantages and disadvantages of this kind of an approach in our
Ad-
country?
in our country, we all know that cancer rates are increasing because of the habits of the patient, right from it could be drinking, smoking, and other non-smoking tobacco products. So obviously, the patients they have to be before they come to know that this is the issue that is with them. Many patients go to the hospital at the end stages of the cancer, probably the second or the third stage. But this disruptive approach, it helps in early diagnosis itself. And moreover, it gives an individualized treatment plans also. And apart from that, AI also gives like which drug is suitable for the patient also. So gives a personalized treatment. I think that researchers have to be employed in this only because to increase the survivorship of the patient, much needed in India because cancer survival rates are increasing in India, and more researches has to be put forth and concentration has to be given.
These are the advantages. Any one disadvantage of this method, if you can, as far as you've read?
Disadvantages is at cost in ineffectiveness, and the other is I would say that anything a nation provides, the government has to support. I don't think that well support from the government is also being there. So if their support is there, we can give a good improvement in this field of oncology.
Oh, thank you, thank you.
Thank you, ma'am.
Thank you, Shweta. So the next presenter will be Priyadarshini. Priyadarshini, are you ready?
Yeah, I'm ready.
You can present.
Is my posters visible?
Yeah, it's visible.
Good evening, ma'am. Myself, Priyadarshini. I'm currently pursuing third year BDS in Chetna Dental College and Research Institute. I'm so thankful to SNO to giving me this huge opportunity to discuss my ideas in this forum. So yeah, from the topic, a disruptive approach to cancer research and survival. Basically, what I understood from the topic is that disruptive approach is making a complex way of finding solution to a problem in a simpler way and easy accessible to everyone. Research is basically finding solution, observing the a problem in our society and finding solution to that problem in an easier way. Cancer is a leading cause of death worldwide, accounting for nearly 10 million deaths in 2020 or nearly 1 in 6 deaths. The most common cancers are breast, lung, colon, and rectum and prostate cancers. Around one third of deaths from cancers are due to tobacco use, high body mass index, alcohol consumption, low fruit and vegetable intake, and lack of physical activity. Cancer causing infections such as human papilloma virus and hepatitis are responsible for approximately 30% of cancer cases in low and low middle income countries. Many cancers can be cured if detected early and treated effectively. Research suggests that around 4 in 10 cancers could be prevented through known modifiable risk factors such as tobacco use and obesity. But by understanding more about how cancer develops and translating this knowledge into more precise interventions, we could prevent many more cancers of the diseases. I suggest bringing biology to prevention will harness fundamental biological insight to provide new targets for cancer prevention. Deepening our understanding of risk, we have to deliver a more thorough and integrated understanding of population and individual risk of developing cancer in order to develop precision prevention measures. We have to deepen our precision prevention measure further, like develop novel disruptive preventive interventions precisely targeted to risk factors and mechanistic pathways through behavioral, pharmacological, and immunological means. Understanding and addressing health inequities in cancer incidences, such as we have to deliver a research to support more effective and equitable public health agenda in cancer prevention. Building prevention research capacity and community. We have to attract new researchers and novel thinking across career stages and disciplines. My aim, I personally suggest prevention is more better than cure. We have to aim for a future of precision cancer prevention based on a deep and nuanced understanding of risk and of endogenous and exogenous etiological mechanisms in the cancer cell, its microenvironment, the immune system, and the whole human. So, before by allowing the disease to develop and then treat, we have to prevent the disease before it is develop and before it is developing. We have to prevent the disease, and so prevention is better than cure, I suggest. Thank you, ma'am.
Thank you, Priyadarshini. That was a good presentation. Now, you said it was a good thing that you think prevention is better than cure. Now, do you know of any measures which are the latest measures taken to prevent the risk factors using this approach? Because disruptive approach is the topic given.
Yes,
So,
ma'am.
based on that, is there any disruptive approach in prevention of a cancer, or how to avoid those risk factors?
We have to identify the key risk factors, ma'am. I think.
Okay. And do you know of any public health programs of anything like that wherein it is targeted to against these risk factors or prevention of?
Tobacco cessation programs were nowadays conducted uh, to cessate that habit in society, ma'am.
Okay. Thank you, Dr. Priya.
Thank you, ma'am.
Thank you, Priyadarshini. That was a really short and sweet one.
Thank you, ma'am.
So the next one to present is Rakshana Prabhaharan. Rakshana, you can present.
Yeah, can you see the slide?
Yeah,
Yes.
it's visible.
Okay. Uh, First, changes in DNA cause cancer. So, CRISPR is the way to correct those changes by manipulating the DNA. CRISPR is actually inspired by the nature. The bacteria in the nature prevent from infection from the virus bacteriophages using these techniques. It is usually like it takes the snippets of the viral DNA and attaches to it. So when the next time when the virus infects the bacteria, it safeguards from the virus. The bacteria safeguards it from the virus. So scientists they adopted that technique to treat the cancer in human beings. First, the full form of CRISPR is clustered regularly interspaced short palindromic repeats. Then what they did is they removed the T cells from the blood and they inserted the NYESO1 receptor. The NYESO1 is the cancer causing antigen. It usually causes testis cancer. The full form of NYESO1 is New York esophageal squamous cells carcinoma cell. So what the NY receptor is inserted in the T cell. So when and by the CRISPR technique. So after the insertion, the T cells uh, are made more in number by the cell culture. Then they are introduced into the human body. By the what the NYESO1 receptor will search for the NYESO1 infected cancer cells in the human body, and when the T cells combine with the NYESO1 cancer cell, it destroys the cancer cells and kill them. So this is how the cancer cells have been killed, and It is tested in patients with multiple myeloma and metastatic sarcoma, and the benefits of CRISPR, it is easily scalable and it is versatile, and we can use this technique with our basic knowledge. Like even the high school students can easily understand this method, and there are only few limitations, but the majority is we can easily use this for treating cancer in most people. Thank you.
Thank you, Rakshana. You finished well within time. Now, for the questions,
Yeah.
disruptive approach is a very big
Yeah.
innovative technology which is happening. And
Okay.
you spoke about one particular method. Do you know of other methods which are being used in disruptive technology for cancer?
Ma'am, there are two other methods like zinc finger method and TASM or something. I couldn't like recollect the exact word.
Okay. Any other method which, simpler methods which are even used in our routine practice? Do you think there are any such methods available? Which this is all you, or do you think this is only research work, or is it applicable even today?
Ma'am, can you repeat the question once
Yeah.
again?
Do you think this is this concept of disruptive approach to cancer treatment is being practiced, or is it only in the research level?
Ma'am, it is only some are practice, but some are only in research level because we have some genetical problem. It can easily
Okay,
like
you said summer practice, right? Can you give me examples of that? That is what I asked.
ma'am, even CRISPR is practiced.
In India.
Not in India, mainly in like foreign countries.
Okay, thank you, Rakshana.
Thank you so much, ma'am.
Thank you, Rakshana.
Thank you.
The next one, the next one to present is Neha. Neha, are you ready?
Yes, I'm ready. A very good evening, ma'am.
Good evening.
And
Good evening, Neha.
ma'am, I'm Neha Chaglan, a third year medical student from BPS GMCW, Haryana. And ma'am, today I would be presenting you my poster presentation. And it is about the discrete choice experiments. And it is titled as Dream of Every Oncologist, Legitimate Expectation of Every Patient, Personalizing Treatment Decisions Using DCEs. So, ma'am, many decisions in healthcare, they are preference sensitive. In particular, when treatments are burdensome, benefits are limited or uncertain, and harms may impact the quality of life. So, they require shared decision making, especially when the benefits are limited or uncertain, and harms impact the quality of life. So, examples are decisions about like adjuvant therapies in oncology or about hip or knee arthroplasty or osteoarthritis. Researchers have shown that patients as well as clinicians often vary considerably in their evaluation of the balance of benefits and harms. In the cancer treatment scenario, this applies as two major questions: whether the patient wants to live longer or live better. And for such situations, patients' preferences do matter. A study has also stated that clinicians are not inclined to foster the choice awareness in the patients, and they often present treatment options in unbalanced ways, like overestimating the benefits and minimizing the harms, and this results in the patient's preferences infrequently elicited. It has also been shown that patients' involvement in decision making leads to an improvement in their perception of quality of care, physical functioning, their satisfaction, quality of life, and also the treatment adherence. That is the most important part. Is also higher for patients who experience an involvement in the involvement that corresponds to their preference in the treatment decision for breast, like it was conducted for the breast cancers. So, ma'am, there are various modalities by which we can assess the preferences of the patients, like the standard gamble, the time trade-off, visual analog scales, discrete choice experiments, and multi-attribute utility instruments. So here I would be discussing about DCEs. The principle underlying the DCE is that the value of an opinion is determined by the value of its attribute. With regard to cancer treatment, this means that the outcomes of a treatment can be described by its attribute, and the extent to which an individual values the treatment depends on how they value those attributes. The main advantage of DCEs over all the other modalities that I discussed is that it talks about simultaneous assessment of multiple attributes rather than a dichotomous choice between one attribute and survival. Hence, they recognize that individuals may value more attributes of treatment than just the quality of life and survival, or that several other aspects of quality of life are relevant. Like, for example, in case of localized prostate cancer, it is the urinary, the bowel, and the sexual function. Also, but one thing that they tell about DC is that they are cognitively demanding because the respondents need to make a simultaneous comparison of multiple attributes and levels of attributes before they make a choice. Hence, the number of choices, attributes, and levels must be weighed against the cognitive burden that they place on the respondents. So, ma'am, in this poster, I have inserted two images. I would be discussing about the one that's present on my left hand side, and it is from a research wherein DC was conducted to estimate the breast cancer patients' preferences and willingness to pay for prophylactic GCSF, that is granulocyte colony stimulating factors, as an adjuvant in the cancer therapy treatment. So, it was for each choice task, the participants were asked to choose which of the two treatments they preferred. And in a follow-up question, whether they would prefer the treatment they selected versus no treatment. So the treatment options displayed as 1 and 2, and no brand name, no generic name was mentioned. So the questions that were asked were about the frequency of GCSF administration that corresponded to the number of injections required for the treatment option. Like one dose was for filgrastim, and other one was 6 doses per cycle for filgrastim. So peoplegrams, that is the visual representation using people images, were also shown to present the levels of the risk of developing an infection requiring hospitalization. So this decision was like they had collected it from various qualitative phases and then they had presented here. And for the risk of disruption to chemotherapy schedule, the levels were presented as low, moderate, and high. So what I want to highlight here is that as science continues to reveal the heterogeneity of the tumors, the number of possible treatment options have arisen, and that has led to the birth of personalized medicine or precision oncology. So this also raises the importance of making best treatment choices, that too for the patient's subject preference. So in the process of reviewing the treatment options, evaluating them in the medical and psychosocial context of patient and matching them with individual preferences and priorities is needed for personalized patient cancer care. Patient involvement is therefore needed to make deliberate choices. So via this, I would like to conclude and say that these studies of preferences for cancer treatments are most useful when the compromise between both of the benefits and harms, they're finely balanced. And this is where the future researchers should focus upon. And so, ma'am, this was all about, and I've also written about a DCE that was conducted, like it was one of the most recent DCE that I was able to find. It was about for a breast cancer, conducted in France and other two European countries, and an image of it is also shown here, wherein I have discussed about the progression-free survival, PFS, the febrile neutropenia, pain, functional well-being, out-of-pocket expenses. So all these things were discussed. They were told in this DCE, and 3 options were provided, and the patient had to choose out of them.
The last 30 seconds.
Okay. So ma'am, this I found it important because as the advancements in cancer treatment are increasing, so does the ethical consideration and the patient's preferences. They also need to be assessed. And researchers have shown that there are still some cancers wherein we need to, like, the future for these diseases about including all the latest cancer modalities. They also needed to be included in the disease and should balance should tell about all the harms and the benefits and all those things that are the attributes that are considered for treating a cancer. Thank you.
Thank you, Neha. That was you have read well and presented good. My question is, this personalized medicine is actually the latest. It does away with one size fits all kind of approach, more of individualized approach, right?
Yes.
Now, are there examples of this personalized medicine? How do you go about it? because genomics plays an important role. Only when you study the genomics of an individual, that is when you can better understand what kind of treatment their individual person might uh, accept. So, are there any examples? How can that be done?
Um,
Do you have any idea about targeted therapy?
yes, ma'am. I read about it.
Okay.
Ma'am, it is said that the cancer cells that are present, they differ in their variability. Uh, it's like um, ma'am, that is like it's like when there are like
You spoke about precision oncology.
yes, ma'am.
Now, this is something in the same line. So, can you explain a little about that? What do you meant by that?
Ma'am, it is about all the molecular biology aspects that differ in person to person. Ma'am, it is said that the various aspects like the immune status of the patient, the lifestyle of the patient, the type of genetic alteration in that cancer cells, all these things are different for different patients, and that is why approaches like that of targeted pharmacotherapy has been included because it's about it's not just that, ma'am, like when we are screening for breast cancer, it is just one mutation like of HER2 mutation. It could be like an amalgamation of other type of genetic mutations too. That depends upon that differs person to person.
Okay. Okay. Thank you, Neha.
Thank you, ma'am.
Thank you, Neha, for a wonderful presentation.
Thank you.
So the next and the last participant, Deepika. Deepika, are you ready?
Yeah, I'm ready. Good evening, ma'am.
Good
Let me
evening.
share my screen.
There is too much of information in this poster. How are you going to do justice in 5 minutes? Anyway, good. You've done a lot of
Yes,
work.
thank you. I just prepared for it to concise it to 5 minutes. Basically, 6 minutes, ma'am.
Yeah.
Yes, ma'am. So, is it visible, ma'am?
Yes, it is.
Yeah, okay. So, to begin with, disruptive approach to cancer research and survival. What does this topic actually mean? A disruptive approach in cancer research and survival refers to innovative and unconventional method to challenge the traditional ways of understanding and treatment. What is being disrupted here? The traditional and the conventional methodology and the system itself and the market behind it is being disrupted. Why does cancer require such an approach? Cancer today is the second most leading cause for death, and global burden of cancer is about 19.2 million with 9.9 million deaths. And overview about the conventional approach is that high-risk patients are screened for these cancers, and positive patients and symptomatic patients are evaluated clinically. Diagnostic and confirmative imaging and histopathological examination are done, and then treatment is being given, which involve only three modalities, that is surgery, radiotherapy, and chemotherapy. In contrast to this, we have the disruptive approach, which will begin right from the research point of view itself. Collaborative research and regulatory changes, such as collaboration among researchers, institutions, and pharmaceutical companies, would involve accelerate the discoveries and drug development. This would also involve fastening the approval to bring the treatments early to the patients. Another important aspect is that in the struggle against cancer, half of the battle is won through its early detection. When detected early, there in the pre-malignant stage, the treatment success rate improves. With that being said, screening approaches here are accessible, affordable, and more effective. Certain examples would be liquid biopsies, home-based screening kits, and AI-powered imaging. Here, I have depicted the liquid biopsy, which uses the protein biomarkers and cell-free DNA biomarkers. Further on, positive patients and symptomatic patients are undergoing diagnostic and confirmatory tests. Then comes another half of the battle, that is treatment. For treatment, we have modalities such as personalized medicine, which involves tailoring the cancer treatment to individuals based on the genetic makeup and the tumor characteristics. And which an example would be the breast cancer treatment, where ER positive patients are treated with tamoxifen. Next would be the nanotechnology, which uses nanoparticle for targeted drug delivery with precision and effectiveness. Then we have the immunotherapy, the important one. This one actually augments our own immune system against the tumor. An important example would be the checkpoint inhibitor, such as the trembolizumab, which basically treats the tumor that have spread to the distant part of the body. And we have the patient empowerment and telemedicine, which involves a better access for the patient itself. And these modalities give new hope and belief for the cancer treatment itself. It involves not to affect the normal tissue and gives the patient free from the pain as a right to themselves. Among these, I found this, that is, the universal cancer screening, an evolutionary, rational, and a realizable approach. Here, the universe of the cancer is screened, that is, the totality of the organs are screened instead of one single organ. I would like to highlight two major studies that has been established. That is, first one would be the Cancer Seek and the Detect A, which involves identification of the mutations in the circulating DNA in the blood, and 8 specific protein biomarkers are also used in the detection. This uses machine learning also as a recent advancement. This is done in a 4-step process. I'm explaining the principle, which is basically the baseline blood test, confirmatory blood test. The positive patients are taken for a confirmatory blood test, then a formal multidisciplinary tumor board, that is, formal conventional screening methods are used. Then they undergo a diagnostic PET scan. Here, the results are obtained in sensitivity and specificity as depicted. The negative predictive value and the specificity is more. And we can see that the positive predictive value improves when the blood test is combined with diagnostic PET-CT. Next one would be the methylation MCED test. MCED refers to multi-cancer early detection. This test is developed by the Grail, and this test is named as Galleri test. This basically involves identification of particular methylation sequence in the circulating cell-free DNA in the blood, and this is proven to detect about 50 plus cancer, and we can see that the sensitivity of this test was 51.5 percentage. Is 51.5 percentage better than the previous treatment. Now moving on to the
Yes.
real, yeah, is the time up?
The last minute.
Yeah, thank you. So moving on with the real world challenges for these tests is the false positive test, which would basically give unnecessary imaging and invasive procedure. We found that the negative predictive value and specificity was actually higher they are focused to be higher in these tests. And another thing is that their sensitivity is low, and they are also more in cost. They are not yet cost effective. So the next step would be for these modalities to come into practice would be furthermore rigorous researches to make them cost effective and to develop them in even more better way. So thank you, and I would like to share my own opinion regarding this. Before this poster presentation or preparing for this poster, I consider cancer to be a completely dreadful disease and no one should get that. And obviously, the incidence is increasing nowadays. And as a future doctor, after getting into these modalities, I think that there are actually better ways to treat cancer, and cancer could be basically preventable, detectable, curable, and treatable. Thank you. Thank you for the opportunity.
Thank you, Deepika. You have done a lot of put a lot of effort and read a lot of books and things to get your poster is uh, very good.
Thank you, ma'am. Thank you, ma'am. Basically, it was interesting as I went through in.
Okay. Now what do you understand by precision oncology, doctor?
Precision oncology doctor.
No, I'm just asking you, what is precision oncology?
Maybe to treat the cancer as not to affect the other tissue and targeted approach to it. I'm not sure about it.
Okay. Okay, fine. It's okay. Do you have any understanding about the preventive methods?
Yes, ma'am. Preventive methods would be for lung cancer to prevent smoking, and for cervical cancer to not have multiple partners, and the genetic certain cancer have genetic inheritance, and they can be also early identified, and such ways prevention can be done, ma'am.
Okay.
And
So,
also control radiation exposure
okay.
for the high risk population.
Okay. It's a disruptive approach. This topic only for cancer diagnosis and treatment, or is it also for the prevention and
Yes, ma'am. As of now, I have focused on the secondary prevention, that is screening. Primary prevention, I didn't find any article regarding it, ma'am.
Okay. Thank you. Thank you.
Yes, ma'am. Thank you, ma'am.
Thank you, Deepika.
Yeah, thank you.
I hope all have presented. Thank you, ma'am, for a valuable time and making this event a really wonderful one.
Thank you, Gina, for the opportunity. And when I think we'll close the session.